Okay. Are you all settled? All right, here we go. Let's see what happens. Dr. Higbee taught clinical pharmacy practice at the University of Utah from 1977 to 1987. He joined the University of Arizona faculty in July 1987 and retired from teaching in June of 2009. He taught pharmacy students clinical practice in nursing homes for 7 years to meet their geriatric pharmacy practice experience requirements, and then taught geriatric clinical pharmacy practice at the Veterans Administration Hospital-based home care in Tucson for the University of Arizona until June of 2009. Dr. Higbee's teaching and practice emphasis is in geriatric medicine. He has experience in the area of geriatric drug research for efficacy, safety, pharmacokinetics, and cost analysis. His studies have investigated new therapies for Alzheimer's disease, pressure ulcers, and urinary incontinence. Dr. Higbee has published widely in the areas of geriatrics and is a co-author of the Geriatric Dosage Handbook published by Lexicomp Incorporated. His long-term and corporate consulting spans over 30 years, and his legal consulting over 15 years. He also presently is an associate with Donahue and Associates, a long-term care and assisted living consulting company. Additionally, he is the president of his own consulting company, Arizona Consulting Pharmacist Enterprises, in which does long-term care, legal, and corporate pharmaceutical consulting. Now, there were some really big words in there, and I'm glad to say that I got through this. Okay. Now, I am so delighted that Dr. Higbee is with us here today. I'm sure you will enjoy him. Please welcome Dr. Higbee.
Thank you. Thank you, Sarah. No, you're fine. You take that with you.
Oh, that's right.
Remember?
No. Don't ever ask me, did you remember? All right.
Listen, I'm there with you. Don't worry about it. Well, it's a pleasure to be back in Billings, or into Montana. I'm from Salt Lake originally and spent a lot of time in Montana. I love this state. So, now, I hope it wouldn't bother anybody if I can't stand still, all right? My first what? Now, see, we're talking about that data. What was that about the divorce rate when they were younger or something? Anyway, my first wife used to say, you're the only human being I know that was born with a time-release amphetamine inside them. All right. I think that translates into type A. All right. You know, I thought many years ago we would quit talking about the basics in geriatrics because I thought, you know, everybody's going to catch up and everybody's going to understand in healthcare. Everybody in healthcare is going to understand the basics in terms of the difference between a 25-year-old and an 85-year-old or a 75-year-old. Well, I find that's not the case because for the last 30 years that I've been teaching, I've had to keep going over it and over it and over it. And a lot of those comments, that last presentation, were about the perceptions that they have of their of the prescriber or the healthcare provider versus also the attitude that was displayed by the healthcare provider. You got to think about a lot of these people who are taking care of older people are younger people, and how do you perceive getting old? Remember when you were 25 years old, you couldn't even think how you could get to 50? Right? Okay. So, and then, you know what's really interesting? I'm going to tell you, you know, we all are biased, right? I still do nursing home consultation. I'm 67 years old, right? So when I see somebody 68, 69, hell, they're young. I don't have to worry about anything. See, that's wrong. That's wrong. Okay, so we're going to review some basics, and then when I was asked to do this, I started thinking, what do I want to talk about? Because I'm getting tired of talking about some of the things I have. But I thought, you know, I'm going just from my own practice, which is a lot of nursing homes. I review charts on about 16 nursing homes monthly in Arizona, 16 different nursing homes. I also am holding down a pharmacy in a mining camp for a friend, and where we have elderly. Yeah, there's people that retire to a mining camp. I could think of better places, but, well, their health care's there, you know? You know, it's a big hole in the ground, that's all they see, that's good. All right. So, I took common drugs. Now, the things I'm going to talk about are common drugs that we use every day in these people, but I see them used incorrectly all the time. And I'll give you some examples if I can get through it fast enough. All right. Just some demographics. You know, you can't start a lecture without demographics, right? Just how many of us are over 65? About 13%. Baby boomers hit us last year, and they're going to continue to feed into this population. It's estimated by 2040, a fifth of us is going to be in that geriatric category, otherwise over 65. And it's not evenly distributed across the United States. I found it interesting on their slide where they showed the states that they had interviews done. They skipped my state. Do you want to come down to Arizona? There's a lot of elderly down there. You know what? And I'll tell you why. I don't miss my snowblower, and I don't miss my lawnmower. So that's why there's so many of us down there living in the desert, living with the coyotes. Okay? Now, the majority of healthcare professionals, when we all started as nurses, pharmacists, nurse practitioners, doctors, dentists, none of us really thought about the fact that a majority of our practice might end up being the elderly. We didn't even think about it, which goes back to my first statement. I thought after a while I wouldn't have to talk about these basics because everybody would home in on the fact that we have an aging population and we see most of the disease process after age 65 or more. Actually 75, but we'll get there. Now, so we got to pay attention to this group. Now, why do we get older? I always love to do this because everybody always points out, well, hey, food supply is better, especially in this country. It's so better, we're overfed. And disease control certainly contributes to the number of people. We have vaccinations, we can prevent disease, we're into preventive care. That all helps. But the number one thing that really has increased our population of elderly is we've decreased, through good science and medicine, we've decreased infant mortality. If you look at most of the actuarial charts, if you can get past the first 2 years of life, which is really critical, then you have a good chance of making it, barring major disasters and major wars, getting into the late 60s, into your 90s easily, okay? So it's infant mortality is the reason we're seeing so many elderly, that decrease. And you can compare that to third world nations where infant mortality is high. You don't see people living a long time. You know, we talk about diseases in this country, they don't even talk about in some third world nations. Cancer? They don't live long enough to have cancer, So why do we focus on the elderly? Well, first of all, I've already mentioned this. We have an increased incidence of chronic disease, right? As we get older, the chances of having some chronic disease, hypertension, diabetes, especially with our overweight problems, and other diseases occur which correlates with age. Now, most of it's after 75. In fact, I understood, and I hope this is still correct, in Russia, they don't consider anybody geriatric until they hit 75, whereas we use 65 because that was picked by a company one year just arbitrarily to say, hey, well, 65 is a good point to start Social Security, and that's where that came from. Now, one of the problems with the elderly is that they display diseases a little bit differently many times, not always, many times, as opposed to the way we were taught. You see, most of the disease presentation and most of the side effect profiles and everything you hear about are based on young, 25-year-old, approximately, males and females. We approach disease process from this young perspective, not the old. And so we don't have a lot of data, and we don't spend a lot of time thinking of the differences. But there's a lot of acute changes that occur. Most often, the thing that comes up, and one of my residents used to say, oh, the big C, and that wasn't for cancer, it was for confusion. But we often see, with elderly, when they get ill, you see confusion as a factor right away. And then, of course, with some diseases, you see lethargy, anorexia, sleep pattern changes, but the confusion and memory loss that occurs with an acute disease is significant. Now, another reason we got to pay attention to these people, they use more drugs than others. And we're seeing that even increase beyond these figures. These are little average figures. Right now, the elderly use at least a third of all the prescription drugs, at least, okay? 45% at least of OTC consumption is in this population. Additionally, take on and the averages are like this. They take about 5 prescription drugs, 2 OTCs. And now we have all these natural products. And I'm not putting this down, I'm just saying, here's a group of pharmaceuticals, if you want to call them that are used heavily by this group, which can complicate their drug therapy. They can lead to side effects It can promote, it can enhance the action of one of their drugs that they're taking. For example, saw a guy come in, I just remembered this. He came in and was complaining he was having muscle cramps. He was taking simvastatin 40 milligrams, but he was also taking red yeast rice, which has a lovastatin-like action. So he was a little bit on an overdose on the statin side. This is something to keep in mind. With any one drug, okay, this is any one drug, an elderly person has 2 to 3 times a higher likelihood of having an adverse drug reaction, i.e. a side effect, compared to a younger person. Now, a lot of that's got to do with changes in body and what happens physiologically in the human with aging. A lot of it's also got something to do with body changes in physiology, and we'll get back to that in a second here. But this, by the way, results in about 10 to 15% of people having a drug interaction ending up in the hospital because of this. This is elderly. If you're in the hospital, you've been hospitalized for some reason, you stand at least a 28% chance of having at least one ADR. And if you have one adverse, and actually this is true for any age group, if you have an adverse drug reaction while you're hospitalized, it generally doubles your length of stay. Now let's talk about healthcare costs. 65% in long-term care facilities, at least one ADR in a 4-year period. So we need to pay attention to our drugs, which is why you'll see me hound on a few things when I get to the potpourri of things. Okay, just to give you some illustrations of what happens with urinary tract, some disease processes and their presentation. We all know about urinary tract infections, particularly women. We're very familiar with this, and we're constantly told in all our classes, the presentation is you're going to have dysuria, frequency, et cetera, right? And that's true. Elderly men and women can have all of that too. But if you notice that sometimes the first presentation is confusion. Because, and I'm going to come back to this again, but any time you take an aged central nervous system and you stress it, when you stress the aged central nervous system, you get confusion. And stresses can come from a lot of factors. It can be drugs, it can be disease, it could be fluid and electrolyte, it could be emotions, it could be environmental changes. Lots of stress, okay? You can get confusion. How many times have you seen this story, this scenario? Grandma's out on her Oklahoma ranch, and Grandpa dies, and daughter in L.A. decides it's time to bring Mom home and live with them because she's all alone on her big ranch in Oklahoma. She gets to L.A., and all of a sudden this daughter's bringing her mother into the doctor because she's demented. You don't develop dementia over a plane flight. Problem is, she's been dropped into an environment she's not familiar with. That's a stress. She gets confused immediately. And I've seen this happen so many times. You take Grandma back to the ranch, and she's fine. So, a lot of times, just moving someone can be a major stressor. Pneumonia. We all know how pneumonia. You got cough. You're supposed to have high fever, a lot of sputum production. But trouble is, with these people, once again, confusion or lethargy comes into the picture. You only have a slight cough. We lose muscle mass as we get older, so we can't generate the cough power that we're supposed to have. And we used to joke with these young residents. Here's what I was saying a minute ago. Young clinicians have a different perspective of old. They would come in, give these people a sputum pump. We used to laugh and say, yeah, give them that sputum pump. Come back in about, a year, and you might have you just might have your sputum. Lower than expected rise in temperature. This is why, how many of you work in long-term care? Yeah, so you see it, so you're familiar with this stuff. You get a temperature of 99 degrees, you're calling the doctor. I've had people look at me like, are you nuts? 99, that's nothing. It's, I'm 98 now. Yeah, well, you don't understand. This is older. 99, when they hit, I saw a nurse freaking out the other night, and appropriately so, she had 102 degrees on an 80-something-year-old gentleman in in long-term care. Now, WBCs, we expect big rises, 23, 24, 25,000 with the pneumonia. You don't see that, right? You don't see that. You see a very slight rise in WBCs and infections. Look, now, I don't know if you've ever looked at this. Look for a left shift. You know what a left shift is? That is indicating we're having an infection. Maybe it's just a rise in the neutrophils. Look for a left shift. How many times have you heard left shift? You've never heard of left shift? Left shift, you hear doctors talking about that, physicians talking about that all the time. A left shift means you have a high preponderance of neutrophils, which are those white cells that are going to gobble up the bacteria and eat them, right? All right, so you see a left shift. I think that comes from laboratory. I used to be I taught laboratory in the military. I think the left shift comes because when you're doing a count of a differential count, the neutrophils are way over on the left, and I think that's where that term probably came from, because you would be counting the cells on the left side of that counter, preponderance, and there'd be a preponderance of left-sided cells, i.e. neutrophils in bands. All right, that's called the left shift. But what's interesting, elderly will left shift within normal limits. You know, the 5 to 10,000 for white cells total, you'll still see a left shift within normal limits. So look for that. That's a kind of a funny little thing. I've had to teach a few people to watch for that. Look at the percentages on that differential. That'll tell you if you got your infection. Don't look at total white count. All right. Here's one I decided I'd come back to this. Again, this is very quick because we've already said it. Anytime you stress the central nervous system, you're going to see oftentimes a pattern of confusion. So any disease, out of control, even if you have diabetes and you get out of control, you can have confusion. Heart failure, out of control, you get confusion. Drugs, anytime you add drugs to these people, you have the potential for increasing the side effect of confusion, particularly, and we're going to get to that, if it's a drug that has anticholinergic action to it. Okay? Anything that has CNS action potential can cause confusion. Emotions. Could be from what I just said, a stressor, bringing somebody a great distance into an unfamiliar territory, a new roommate, anything, problems in the family, anything that's an emotional factor. And then, and this is a little bit of a repeat, but whenever there's an acute change in mental function, the first 4 things I want you to think about, there's a lot of reasons for changes in mental function, but acute changes now. They're good one day and they're not the next. Well, and think of infections, drugs, fluid and electrolyte status, and environment. Okay? And what I mean by environment is, did they get moved? We had one gentleman in a nursing home. We literally moved him across the hall from his present room, and he would be disoriented for 4 days. You could almost set your watch by it. On the end of the 4th day, it was like, bingo, he was back home. Just a move across a hall, let alone across the country, across the state, or something of that nature. So, or, hey, how many of you have gone through this? Oh, I love this. Anybody done reconstruction in a nursing home? Yeah, what they need to do is get a keg of wine and put it on just mount it with a little spigot and plastic cups, and that's for the nurses. Okay? And then you get Jack Daniels for the residents. Okay. Environmental changes have a big stress. Okay? All right. Let's go through some physiology, because people like to point out different organ systems and the way they change with age and try to affect drug action. Okay? Well, one of the first things, how many times have you heard, elderly don't absorb drugs as well as younger people? No, that is not true. Now, there's a lot of reasons that we could come up to that, sort of speculate this. For example, there's a decrease in gastric acid secretion. There's decrease in gastric emptying time. Transit time through the gut is cut down. There's a decrease in splanchnic blood flow. The blood flow to the gut, if you want to look at it that way, instead of that big word, splanchnic. All of those you could say, oh, see, that would affect how drugs get absorbed. Well, drugs, for the most part, have passive diffusion. That doesn't change. So you find you may have some delays in absorption to the time to peak. You may have some blunting of the area under the curve. Area under the curve, another way to look at that is how much drug's in the blood. Area under the curve is over time, how much drug got into the blood. That's the way to look at area under the curve. You may blunt those, but that affects PRN use. When you are constantly and chronically administering a drug, you're taking it daily or twice daily, then it doesn't matter. There's no change in the absorption per se. Even though if there is a blunting of the time to peak, it doesn't matter because over 5 half-lives, you're going to reach a steady state with what was absorbed and what's excreted, okay? There's no change. So, here's the bottom line for this slide. Do not blame a failure to see a response on the GI tract, please. Not in the elderly. It's not a reason. There's other factors to be looked into. Inappropriate dosing, drug-drug interaction in the gut, underdosing, I already mentioned that, inappropriate drug. So let's not blame the gut. I went backwards, I'm sorry. Now, just for fun, and just to get out of the way, because we have so many dosage forms that are used on the skin, there are some changes that occur. Okay, what happens with our skin as we get older? It gets dried out. Why? Right, it gets thinner. We get that parchment thin skin, which I've already got. My dogs and cats and horses keep constantly bruising me, but that's okay. We lose the lipid layer in our skin. That's what holds the water in. That's why it gets drier, right? It also, instead of having elastin, we replace elastin with collagen, and that's why we get that parchment thin tissue that tears so easily. And taking aspirin, like most of us probably are, then you bleed like hell, and everybody thinks you're dying. But you're going, oh, look at all that blood. Yeah, well. People overreact to blood, don't they? I mean, I know you guys don't. You're used to seeing it, so. All right, so that affects, so it's right, oh, by the way, it's lower lip is for lipid. I'm trying to conserve space on these. So we've already mentioned this. Now, yeah, you can have a lower lip content too. We've talked about those thin-lipped, I know. All right. This affects drugs that are fat-soluble. So drugs like that we're seeing, the fentanyl patches that are used, the estrogen patches that are used, and the testosterone patches that are used. So that can affect them. You have a decreased absorption. So it alters the absorption. There's no way to account for that. That's why we titrate. Okay? That's why we titrate and watch for and monitor for response. Now, hydrophilic drugs like acetylsalicylic, say, using some of those patches for pain, it's not much affected. It shows less reduction in absorption. And then it's interesting, anything that's used transbuccal, your nitroglycerin, whatever, the Densitron ODTs, there's no change with age in the mouth. You put it under the tongue, it gets well absorbed. So nothing happens there. All right, now here's one of the big organ systems that changes with age, okay? The liver. And there's no way to quantitate what happened in terms of dose reduction. This is probably where it's best to say that old adage, with a drug you start low and go slow, and here's the reason why. First of all, we do have a decrease in liver mass over age, anywhere from 20 to 40% decrease in your liver mass. As a result of that, probably, that's why we decrease blood flow as well. You haven't got as much tissue to perfuse, so the blood flow drops off. Now, where this affects drugs are drugs with first-pass removal. That means as they get absorbed and start to go through the liver, there's an extraction rate. They're pulling them out. But if we have less of an organ and less blood flow, less of the drug is going to get extracted on this first pass. Does that make sense? Yeah. Okay. And what drugs are those? I mean, you have atorvastatin, Lipitor, propranolol, big one, atorvastatin, verapamil. Some of these aren't so important as except things like labetalol, amitriptyline, metoprolol, dizipramine, and imipramine. Yes, and they're still all used. So you could see a slightly higher blood concentration than you would see in a younger person. Do you see that? That's why we start low, go slow. Because if the liver's not going to destroy it as quickly as it can when you're younger and remove it, at a standard dose, we may see just a slightly higher serum concentration in the elderly. And thus the reason we see adverse effects at doses we wouldn't expect them many times in the elderly. And there's other drugs. Most of the drugs get passed through the liver. There's not very many drugs that go through the kidney, really. All right, so that's one alteration in the liver we have to pay attention to. There's also this, which impacts the other one. We always talk about that cytochrome P450 system. I hope you're not trying to memorize which drug goes with which. I mean, the list is long and it's impossible. Why, you know, as Einstein said, why do you memorize things you can look up? But, well, somebody asked him his phone number one day, and he got out the phone book and looked it up. They said, man, with very great intelligence, and you can't remember yourself. He says, I don't call myself. Why would you memorize something you can look up? Yeah, got a good point. That's always my excuse. But anyway, just to show you, we talk about there's a great variability in metabolism in individuals, let alone the elderly. Well, here's the reason why. You know, if you look at with age, the 2C19 fraction, some reduction in action, and there's, I don't remember what drugs go through 2C19. I look it up all the time. And then there's the 2D6 fraction, which a lot more drugs go through. It's like, I think, verapamil and things like that. There's no change. But then, where the majority of drugs go through, right here, these four fractions, it's variable. So there's no way to quantitate. If you take an elderly person and say, well, they're 79, maybe we should cut down 25%. No, there's no way to do that. You just have to be aware of this fact that it's a general change with aging, and we start low, go slow, monitor, monitor, monitor. And the patient can do some of that monitoring. So there's a wide patient variability from patient to patient, even within the elderly group. So you can't do it just by age. Now, that's all called phase 1 metabolism, right? This is the easy part. See, there's 2 phases of metabolism, phase 1, phase 2. That's it. That's easy, okay? Now, phase 2 doesn't change with age. Phase 2 is where you add a glucuronidate, something, otherwise you put a sugar on it and make it water soluble. The whole idea of phase 2 is to make everything water soluble so it can go out in urine. That's the phase 1 prepares the chemical to go to phase 2 so we can eliminate it in the urine. That's that simple, okay? We make it water soluble over here on the glucuronidation, the sulfation, acetylation. In fact, remember those some of those the OBRA regulations about benzodiazepines? They favored using short-acting benzodiazepines over long-acting. The reason is because short-acting benzodiazepines do not go through phase 1. They merely go through phase 2 and are rapidly eliminated. So we see short durations of action. That was one of the speculations, the rules that were set forth based really on some physiology. It amazes you the government would think that way, wouldn't you? But anyway, they did. So that's why short-acting benzodiazepines by most of your healthcare regulations in nursing homes are favored. It's based on that fact. All right, here is the one system that's been changed, and we all know about this, right? Well, maybe all of us. I'm always amazed in nursing homes and in the clinic that I'm associated with right next to up in the mining camp. I'm always amazed that people tend to forget that there's a decline with renal function with aging, okay? All right, what happens? Well, a lot of things. Renal mass declines. Renal blood flow declines. That's probably because the mass decline. I mean, there's no sense in perfusing something that isn't there. GFR, the glomerular filtration rate, falls off about 10% per decade after age 40. Anybody here over 40? You're not what you used to be. Yeah, no kidding. I know, I feel it every day. Filtration fraction starts to fall off, and tubular secretion slows down. So that's why you see more dilute urines in elderly people. Okay, so what do? We have to account for some drugs and drug categories when we have to deal with the renal system. Now, first of all, let's get one thing straight. When you take this is not taking people with overt renal disease. We're talking about normal aging kidneys. And what you will see is that serum creatinine remains normal. If you draw a line, you put age and serum creatinine value, it's almost a line right across with age in normal kidney function, okay? Now, why is that? Because where does creatinine come from? Muscle. It's a byproduct of muscle metabolism. When you're using your muscles, you're creating creatinine. We just happen to use it as a marker of renal function. Well, here's the problem. Whether you like it or not, I know you've seen the ads on television, drink all that protein stuff, keep your muscle mass. We lose muscle mass with age. Therefore, our creatinine production will be less with age, right? So that's why it remains, even though we're seeing creatinine clearance decline with age, the serum creatinine, when you just look at that number alone, kind of stays constant. So that's why just looking at someone's serum creatinine is not a good reflection for looking at the elderly for renally clear drugs. You've got to do something else. You need to look at the GFR. Have you noticed a lot of the labs now are calculating a GFR for you? That's the reason why, right there. Because just looking at a creatinine is worthless. Okay. There's a lot of drugs, and I'm going to come back to some of these that you need to consider. I know, everybody thinks allopurinol is a benign drug. No, it's not. And it's cleared renally. It's actually not allopurinol. I'll come back to this. It's not the allopurinol that's cleared renally. It's the active metabolites that are cleared renally. Oxypurinol. But other drugs, digoxin, big time. This drug you got to watch because it's a renally cleared drug. Cimetidine, now, although I point out cimetidine here, you know, a lot of people use famotidine, they use ranitidine. Have any of you noticed people who take 150 milligram dose of ranitidine get confused? I've seen it. We used to be very careful because a lot of people think these are just benign drugs. Oh, you know, Pepcid, and I said, they're not going to hurt you. I said, be careful in the elderly, especially with renal clearance. I've seen cimetidine we all knew about. Oh, I didn't mean to do that. Cimetidine we all knew about because it's totally renally cleared. And it would get into the brain and cause confusion. But then they came out with ranitidine and famotidine, and everybody thought, we're safe now because they don't get into the brain. Well, be careful. Because I've seen people get confused on those too. And I mean frank confusion. You stop the drug, it clears. A lot of the parental antibiotics, the carbapenems, I don't know why I threw that one in, the imipenem. Glyburide, glipizide, all the sulfonamide drugs, the atenolol, a lot of agents, and there's more. These are just common drugs that we see on a daily basis. Need to think about these drugs in terms of renal clearance. Now, you got to use real caution with people below 30 mils per minute, and a lot of elderly can fall into that group, 20 to 30% maybe. And another thing I'll come back to, we're seeing a lot, I'm not technical, okay, I'm old. Leave me alone. Caution here, but are you seeing all these magnesium products? I have one doctor up there, he puts almost every one of his patients, tells them, go get some magnesium and take magnesium. You got to be careful. Lithium's on the rise again. I've got several patients in several nursing homes back on lithium. Okay? It comes back, drug cycle. First they're bad, then they're good, then they're bad, good, then they're bad. It goes back and forth. Meperidine. I don't like that drug anyway, but I'll tell you why. Orally, I should say orally, because it isn't well absorbed. But nonetheless, everybody gets one thing about it. It's a good analgesic if you get a good concentration. Excellent narcotic, okay? Except there's just one problem with meperidine. It breaks down to normeperidine, and normeperidine, the metabolite, has no analgesic qualities whatsoever, but it can cause things like seizures. I had a hospice nurse one night that I called up 11 o'clock at night. I was in a nursing home. I know, that's when I work. I'm in this nursing home, and I called her up, because here's this patient's chart. She's, I forgot how old, 75, 76. Opened up the chart, right at the very top in big letters, chronic renal failure. They had her on meperidine, at least 100 milligrams, Q3 to 4 hours. I liked that. That was good interval. But her creatinine clearance was 10. So I called, I thought, I better call this nurse. If I get her up, I'm really sorry. So I called her up, and I warned her about, she said, no, I know. The doctor knows. Next day I got a call, and all I heard when I answered the phone was, oh my God, she's seizing. I said, I told you. Well, it's because you have to consider normeperidine. Anybody with low creatinine clearances, be very, very careful with the use of meperidine. All right, here's how, this is the most frequently used equation, right? Creatinine clearance equals 140 minus the age with the ideal body weight divided by 72 times the serums. I know it isn't spelled right there. Now, there's another one here with a problem. If you get the second one, Shirley said she's going to buy you a BMW. Okay. With this, now I've seen physicians and pharmacists and everybody make errors here because with women, after you do this calculation, then you have to multiply it by 0.85 or 85% to adjust for the difference in males and females. And it does make a big difference. By the way, when you're dealing with the elderly, if their serum creatinine is less than 1, then just use 1 as the serum creatinine. Just fudge it right up because it'll correlate better. And there's a lot of controversy about what do you do about people's weight. Do you use the ideal body weight or you use their actual body weight? And in kilograms, don't forget, if you get somebody, if you do a calculation and you don't change this to kilograms and you put in their actual body weight, you'll get creatinine clearances that only Superman could have, okay? So, and right there should tell you did something wrong, okay? 200 mils per minute, hey, my God. Yeah, something wrong. Okay? So just FYI, if you use people who have less than ideal body weight, it underpredicts their creatinine clearance, and people who are obese, it overpredicts what they're capable of. So just FYI, just kind of, you have to use common sense, okay? Just use common sense. These numbers aren't hard. Don't try to make it hard. Okay, real fast, just for body alterations and what happens with drugs and why we see maybe reactions that we didn't expect. As we get older, I already pointed out, we lose lean body mass, fat content goes up, I'm sorry. But we do put in a little more, we do have an increase in fat. Therefore, since muscle mass decreases, that's where most of our water is. So we have a decrease in water, in the water bucket. Now, the way to look at volumes of distribution, it's like you have a container. And you're going to put a prescribed amount of drug in there. Depending on how much fluid you got in here, you're going to change the concentration, right? Follow? Yeah. If it's full and you put in 0.25 of digoxin, you're going to get one concentration, but if it's only half full and you put in 0.25, you're going to have a higher concentration. Make sense? Yeah. Same with fat. So what happens? With drugs that are fat dissoluble, there you have a larger volume of distribution with estrogens, benzodiazepines, narcotics, antipsychotics, antidepressants, a lot of lipid-soluble drugs. On the other hand, drugs which are hydrophilic, or like water, like your aminoglycosides, and also, by the way, the rest of the penicillins and such, digoxin particularly. There was a study done with digoxin in elderly versus non-elderly. And they took into consideration and factored in changes in creatinine clearance. You know what they found out? At a standard dose, elderly men, they were over 70 versus under 40, elderly men in this study had, at the same dose, they all got 0.25 of digoxin a day, okay? At the end, and they let them go to steady state. At the end of the study, factoring in body weight, creatinine clearance, elderly had twice the serum concentration of younger people. Why? Because of water changes. It's significant, okay? It can affect how you see the action of that drug. Theophilin's another one. And here we go back to lithium. Seeing a lot more lithium come back all of a sudden. Have you guys seen that? You have? Okay. Yeah. Well, that's a good drug if you know how to use it. All right. Alterations, to continue here a little bit. Binding. Serum albumin. A lot of drugs bind to serum albumin. We know that. In what most healthy elderly, we're fine. We do have about a 1 gram per deciliter drop over your lifetime. You drop about 1 gram. But that's still within normal limits, and it's good. You're all right. But we see a lot of frail and malnourished elderly, and that can affect some drugs because they're one in particular, how about phenytoin? Well, there's a lot of them, really. Warfarin, phenytoin. There's other drugs, though, we need to think about. I threw this one on only because a lot of people don't know that furosemide is 90% bound. But we can see changes in the response to these drugs if we don't stop and just think about this. Is there albumin low? I just had a legal case where somebody didn't take that into consideration and they gave 2 doses of phosphenicoin and they wondered why the patient ended up on a respirator. Oh, I don't know. When you have low serum albumin, your free fraction increases, right? It's the free fraction of a drug that gives you the pharmacologic response. Okay? All right. Common therapeutic problems. Here's where I get to have some fun now. Okay. Not like I'm not, you know. All right. Here's the deal. I picked on all the drugs that I see common problems with. Anything with anticholinergic action, you know what that is. That's that dry mouth sensation, right? Any one drug. This could be Benadryl. This could be chlortrimetine. This could be disopyramide. Doesn't matter. Any drug with significant anticholinergic action can give you cognitive impairment, up to 50% of cognitive impairment. How many times have you watched the elderly come in during the hay fever season, and they get their Benadryl or something like that, and they go out, and the next thing you know, they're totally seen it constantly. First generation, who are the big offenders? First generation antihistamines, I just mentioned, the Benadryls, the chlorpheniramine, and that kind of stuff. Antipsychotics, the phenothiazines. Still see them used. I know we have all the new novels that have their own problems, but we see all the novels. I'm still seeing a lot of phenothiazines being used, and they can cause you problems because of their anticholinergic action. The antidepressants, the old tricyclics. Do we still use the old tricyclic antidepressants? Yeah, not as much to treat depression. Now we're using them for pain, but nonetheless they're anticholinergic. The Elavil, which is amitriptyline, which is, in my mind, a no-no in most elderly. 99.999%. Doxepin, nortriptyline's maybe okay, but I still see a lot of those prescriptions. So you want to be careful. Urinary incontinence agents, even though we have these very selective agents like Vesicare, I've seen a couple of our gentlemen get very confused on Vesicare. And I'm not picking out that drug. It's an excellent drug, and it does have less CNS action than oxybutynin, but you still have to watch out for the anticholinergic actions. Okay, why do anticholinergics cause confusion? All right, as we age, the production of acetylcholine, or as they say in England, acetylcholine, production in the brain diminishes. It's acetylcholine that we're all using right now to focus, pay attention, memorize, etc. That's what runs our brain. That's our major neurotransmitter. If you decrease the amount of acetylcholine going across the synapse, you get confusion. The word anticholinergic have a meaning? Yes. It blocks the action, and so you can see profound confusion. Okay? All right, another drug, another pet peeve of mine. I see these 75-year-old plus particularly getting allopurinol at 300 milligrams a day. And I've actually seen a few people have some balance problems as a result. You have too. Thank you. I'm glad to. How many else have you seen problems with allopurinol? Is this the only observer here? Is that? I've seen it, and it can happen. And see, we've all thought for years, oh, allopurinol, put it in the water, it won't hurt anybody. Well, it can. You look at the way it's supposed to be dosed on creatinine clearance. Most of our elderly are between 20 and 60, more often not hanging around 40, over 70. Look at the dose for a day. And you see 300? Now, could that be altered? Could some elderly do well and need 300? Yes. But why don't we monitor our uric acid and see what dose we need to achieve? Okay? To maintain that uric acid in a safe level. And hey, where do you want your uric acids? Below what number? I see 6 and 6.5. 6.5 would be good. All right. Here's another one. Well, this is the problem with allopurinol. The half-life of the parent drug is only 1 to 3 hours, so it's not the problem. It's the metabolites, which range from 2 to 75% of the drug as it's metabolized, and it gets on the higher end for them. Oh, I didn't mean to do that. See, I told you. Right here, it's this oxypurinol that causes all these problems. Well, look at it, including GI bleed has been reported. So you got to be careful. This is not a benign drug, and so let's pay attention to how we're dosing that drug. Besides, why give more drug than you need? Okay, just a general principle. Okay. All right. Here's another one. Antipsychotics for dementia. Did you hear about this 85-year-old gentleman that hadn't been feeling well and went to his doctor? And worked up and worked up and worked up. Went back one day to get the results of all the workup, and he walks in and the doctor says, "Oh, sit down. I've got bad news and worse news." And this old man says, "Oh, no. Well, what's the worst news?" And he said, "I hate to tell you this, but we have found you have disseminated cancer through your body. There's nothing we can do about that. We're just going to have to make you comfortable." He said, "Oh, dear, worst nightmare in a human's life." He said, "Well, what was the bad news?" He said, "Well, after all that extensive testing, we've come to the conclusion you have Alzheimer's disease." And he says, "Well, at least I don't have cancer." Okay, so much for dementia. I promised myself I wasn't going to tell that, but I forgot. So, all right. Here's the problem with using antipsychotics to treat behavioral symptoms with the elderly. And I've been yelling about this for years. And people don't care about research, they care about what they think. I know, there was another little, did you catch the, not there, excuse me. Here's the other typo that could have won the BMW right there. It's only, use in dementia for agitation and psychosis has only a moderate benefit. These agents, people overuse them. I'm sorry, have any of you ever taken an antipsychotic? I'll tell you what, on your next day off, ask your pharmacist for a half tablet of, let's say, Risperdal. Just take a half milligram and see how it makes you feel.
Stick your lips to the wall.
Yeah, stick your lips to the wall. Oh, it's terrible. I don't know how these people survive on these agents, but there are people who need them, no doubt. Schizophrenia, bipolar, etc. I know. But the elderly with dementia. First, the problem we have is we oftentimes, and I'm speaking to the choir here, I realize, because nurses know how to handle this problem better than, and I'm sorry if there's a physician in here, I don't mean to impugn you, but God, physicians just throw these drugs at people and walk away, in the nursing homes particularly. We want to identify the specific targets, symptoms. Well, I don't have time to tell this story. I wish people would get it straight. You know, what are you treating? You're treating a psychotic behavior, or are you seeing anxiety, or are you seeing signs of depression? Let's identify what we're seeing mostly and use the drug appropriately for those signs and symptoms. Okay? Anxiety is very common in this group, particularly when you move them into a nursing home. Who wouldn't be? I think I'd be anxious moving into a nursing home. And by the way, anxiety often is found, you find 90% of people with depression will have anxiety. So now you got two things here cooking. We used to start on our geriatric service, I helped start the geriatric service at the VA in Salt Lake City. And we used to always start with people who, unless they were clearly psychotic symptoms, we would start with an antidepressant. Because, why? The literature demonstrates that at least 40% with dementia have an underlying depression that is giving you your symptoms. Okay? 40%. Well, when you have these psychotic symptoms, the best the literature has been demonstrating now for over a decade is about a 30% response. Isn't that pathetic? A 30% positive response. And by the way, it has a short duration because it only lasts for about 3 months. Which is why, once again, I can't believe that somebody in the government came up with this, but remember those old Dobra regs, and they said, you know, after about 6 months you ought to try a reduction? Here's part of the reason why. They have limited effect anyway. So get them off of it, because all you're going to get now is side effects. Make sense? That's true of a lot of drugs in this population. Try to wean it down. You know, now with the risks outweigh the benefits with these newer agents, you know, the Risperdal, the quetiapine, and Seroquel, which is quetiapine. You know, I mean, all we're using all these agents in big doses. But if you look at the literature, the risks are outweighing the benefits because of why we're seeing cardiovascular complications, we're seeing arrhythmias, diabetes and weight gain, high cholesterols now. These are not safe agents. These are big guns. Now, am I saying don't use antipsychotics? Absolutely not. You select that you need, you start low and you titrate up, you get your response, then after a while, if they're oriented and everything's going well, you can try to reduce it. Most often when we see these, particularly in long-term care, used is when somebody comes in. It's a new environment and they're going to have confusion because of the stress. We see the outburst, we start the drugs. Once they're oriented, they know the faces, they know their roommates, they know the people in the hall, they're used to the noise and the level of whatever's going on. A lot of times, most times, you can take these drugs away. Remember when the OBRA regulations came into effect? Everybody was going nuts and throwing up their hands and, my God, what are they trying to do to us? I mean, they don't practice medicine in Washington. You know, they don't practice anything but thievery. But anyway, well, oh, I didn't mean to say that. Okay, I'll vote for president. No. All right. The thing is, they came up with that regulation. You know, let's get these. Let's start reducing these agents. And you know, it was amazing. The nursing homes would go in and they'd say, "Oh, you know, Martha's doing so much better. We stopped that Seroquel." And that wasn't then. That was Haldol back in those days. Vitamin H. You know, everybody needed Haldol. And there's so much. They're eating better, and they're going to activities, and whoa, surprise, surprise. Hey, like I said, on your next day off, take an antipsychotic and see how much you enjoy your day off. It's miserable. So, phenothiazines are still out there, but keep in mind that anticholinergic action, which, by the way, it's not just the brain. Whenever you hear anticholinergic in elderly, think bowel, brain, and bladder. They can get constipated. They can have bowel problems with incontinence. I mean, it's just terrible. Okay. So, bottom line is, why don't we just use these as little as possible? Monitor, monitor, monitor. Non-pharmacologic, which you guys are the best providers of. All the nurses, LPNs, CNAs, all of you. I can't tell you how much appreciation I have for you, particularly in long-term care. I mean, you guys do a remarkable, remarkable job. I know the physician likes to take the credit for it, but they're in there for 15 or 20 minutes and gone. And like me, too. I go and they go, "How often do you come in?" I said, "Once a month." So, you know, I see what I see. That's why I love, when I do most of my nursing home consulting, it's at night and on weekends and holidays. Why is that? Because I can talk to nurses. I'm not trying to butter you up. But if you want information about a patient, talk to a nurse. Don't talk to the doctor. Don't read their notes unless it has something significant you're looking for. You know. No, I'm not putting doctors down, but they don't know the patient as well as you do, right? Oh, okay. I don't know. I probably have no time, but here, I'll give you a quick story. I went into a unit one day. We were going to do we had been asked to consult on one of our patients in the VA over at the University Medical Center in Utah. We went in. It was a Saturday morning. Dr. James Woods, my geriatrician I worked with very closely, we walked in. And, you know, we were just dressed in tie and shirt, and, you know, we didn't have the white coat on and a big impressive name tag or anything. We just walked in. And we were looking at this patient, and we walked up and we looked. He had IHSS, right? Idiopathic hypertrophic subaortic stenosis, IHSS. You know, that's where the left ventricle expands. They don't know exactly why. Pushes down on the aorta, so you get subaortic stenosis, like stepping on your water hose at home, okay? Well, what happens when you do that, you get epinephrine release, and so what happens to heart rate? It goes off the wall. These people are laying in bed asleep almost with heart rates of 150, 160. Okay, how did you treat that medically? Well, you use propranolol. Okay, so here's the scenario. We walk in. This guy's laying there like he's asleep. Check his pulse. It was still like 150. And yet he was supposed to be getting 40 milligrams of propranolol QID 4 times a day. So I went out to the nurse. I said, "Hey, can I see your MAR?" She said, "Sure." I said, "Hey, Mr. So-and-so." She said, "Oh, he won't take 1 dose of any of his drugs." So he hadn't received any propranolol because he refused it. Okay? So in walks the new people on the scene, the new gods to save the world. The residents. And they shoved the attending aside like he's just an old bag. And I went and leaned against the wall. I was curious to watch this play down. Young resident, well, it's still 150. Better increase the propranolol. I said, why would you do that? He says, well, this patient has what's called IHSS, and if this is a condition, Jim Woods, the physician attending, said, Dr. Higbee's well aware of what IHSS is, but he's asked you a really interesting question. Why would you increase the propranolol? And then the facade fell apart. He says, well, kind of like a politician when you ask him a question. I said, this gentleman hasn't had one dose of propranolol. I love this response. This should have been recorded. That's impossible. I ordered it. Oh, excuse me. Excuse me. Oh, my God, how could I miss that? So, I talk to nurses a lot. All right. All right, I've got to hurry through. Here's a fave of mine, the bisphosphonates, the Fosamax, the actinils, etc. You know what? I see order after order after order written for these and no calcium. Huh? I love and how about the myocalcin, the calcitonin nasal sprays? I asked one doctor, why don't you order some calcium? He says, well, aren't they getting that in the myocalcin? I says, calcin? Yeah, let's blow 1,500 milligrams of calcium up your nose and see how long you stay plugged. It's just insanity, okay? It's insanity. These agents need to have concomitant calcium in order to be effective because all the drugs do is alter the cellular function of making bone. Need to give them the substrate. And magnesium is being thrown in there too, by the way. And there's some doses there for you over for ages. You need divided dose. Don't give it all at once because calcium has a very slow absorption. You have to divide the dose out to get maximum absorption. Now here's our proton pump inhibitors. You've been seeing all the problems with them? Oh, this was a benign group of drugs, right? Oh yeah, now we've got wrist fractures, hip fractures, Clostridium difficile infections, atrophic gastritis, hypomagnesemia reports, one after another. But there are some people who are going to need them. So what do you do about that calcium loss? So the reason they have calcium loss is because if you lower the pH, you don't absorb as much calcium. You need the high acid content to absorb calcium, to put it in the right form. So what you do is just replace calcium and add it with D. We're all D deficient. Did you see all those reports? About 70% of us, even though we're in the sun taking multivitamins, are vitamin D insufficient or deficient. So I just tell everybody, hey, take 1,000 a day and be done with it. Okay. And I even do that. I've never been tested. My wife was, and she was low, so I've got her on 1,000 a day. I take care of her. But if you hurt her, she takes care of me. So it works both ways, right? We're married. All right. Benzodiazepines. I've already kind of mentioned this. Avoid the long-acting. You know, I would have thought 20 years ago we had got that straight. Avoid the long-acting. Why? The long-acting benzodiazepines have active metabolites. The active metabolites have half-lives that are longer than the parent compound. There's an example. Diazepam, Valium, has the parent compound, 20 to 50-hour increase. A half-life. The active metabolites are 50 to 100 hours. That's why people, when they were taking them for anxiety when they first came out on the market, you'd see people take them, and then all of a sudden they wouldn't be getting their refills. Well, they had an accumulation of the metabolite. They didn't need it as much to stay less anxious. And why the problem with the benzos, especially the long-acting? They're associated with falls particularly. And also confusions come up, and so you got to be careful. There's some association between long-acting, you can go to the literature. Long-acting, you see more falls you do with short-acting. So the short-acting agents have less duration of action because they also lack active metabolites, and that's a lie with Xanax. It has an active metabolite, but it's considered short-acting because the active metabolite has the same half-life. So. Iron supplements. Oh, I wish I had time to go through this. This just bothers me. I know iron's cheap, right? But how many women in here have taken iron? How many of you enjoyed it? That's what I thought. Constipation is a problem. It makes you nauseated. You don't want to eat. We already give these people 35,000 tablets in the morning and then want them to eat breakfast. So the thing is, as we get older, our bone marrow reserve decreases. So what you see is a decrease in the number of red cells. Now, if the number of red cells is down, what happens with hematocrit and hemoglobin? It's down too, because it's just a measure of those, right? Okay. Have you ever noticed that the indices remain normal? That's typical of the elderly. The CBC indices remain normal. That's what you want to look at, particularly MCV. Well, I like MCV and MCH. MCH is just a percentage. The ferritin's usually within normal limits. Serum iron may be low, and that's just only because the stores of iron don't get metabolized in the reticular endothelial system as well as we get older. For some reason, it's not known why. So your serum iron might be low, but what I always find is I see these TIBCs. Total iron binding capacity is normal to low. In fact, I love to see them when they're low. When you have a low TIBC, that means you've got so much iron hanging around, don't walk next to a magnet. Okay? Total iron binding capacity. If you want to talk to me later how they measure it, and you'll understand what TIBC means. But it's the iron binding capacity. When it's low, it means you got lots of iron in your system. Okay? Now, problem is they never look at ferritin. So go ahead. There's a lot of things. I'll just leave these in your notes. There's a lot of things that can give you a high ferritin. And you need to rule those out. But you need to look at serum ferritins and get an idea. If you've got enough ferritin, you probably and you have normal indices, you don't need iron. Okay? All right. One last thing. Two last points. Magnesium. It's a real problem. Everybody's getting magnesium, but remember what I already told you. Elderly often have creatinine clearances are low. If you accumulate magnesium with hypermagnesemia, what you see is confusion. Anybody seen that in somebody? Profound confusion with hypermagnesium. With low magnesium, you see all these problems. Neuromuscular spasms, weakness, tremors, hypokalemia, hypomagnesemia. So be careful. That's with hypomagnesemia. And convulsions, I've seen that. Nitrofurantoin, commonly used, just one warning. You need 60 mils per minute of creatinine clearance for it to be effective. I see this all the time. For UTIs, it won't work. And then the last thing that's on there is just nonsteroidals. Just be careful. Nonsteroidals, elderly can have a lot of gastric hemorrhages with nonsteroidals, high percentage, but do we use them? Yes. But just be monitor. The one in particular that's really kind of fun to watch is indomethacin. Indomethacin, I've seen one dose of 25 milligram indomethacin make an elderly person confused. I'm through. I've got to quit because they're shooting arrows at me going. Thanks. Thank you. And it's been a pleasure, believe me. Thank you.
Okay.
Oh, you're
Not
welcome.
shooting arrows. He is excellent.
No.
Thank you, Dr. Higbee.